everybody. It's Ryan here, your friendly physician. Hope you and your family are well and hope you're in good health and strength. God bless you so much. Thanks for joining me. It's our sixth clinical case study in internal medicine. We're looking at palpable purpura today. And if you haven't yet subscribed to my channel, I hope that you will consider that. So we're basing this whole series on what was said by Sir William Osler. He said, and I quote, "He who studies medicine without books sails an uncharted sea. But he who studies medicine without patience does not go to sea at all." Yep, we're trying to marry the theoretical aspects and the practical aspects of medicine together in the way of case-based scenarios. Each for a case will have the following format. We're going to look at the presenting problem in terms of the symptoms and the background, and then try and formulate a differential before we examine. Then we present examination findings and ask, has this defined our differential? Then we look at investigations and further pose the question, have investigations now of the differential, and then treatment and management. So this is designed to simulate a case with a real patient in real life. It's actually based on actual cases. Okay, so palpable purpura, let's go. 65-year-old woman has a long history of psoriasis and psoriatic arthritis. Presents with a 4-day history of rash on her lower limbs, lethargy, and fever. So what's the big deal? She has psoriatic arthritis, but now she's coming with a different kind of rash. This rash is quite different. Rather than being red and scaly, it's purplish and in some areas almost black. Now, this lady says that these lesions started off as kind of small papules which have blistered. The affected area has extended, and now there are large purplish lesions which are beginning to so-called break down. So the epidermis is probably being sheared. Besides psoriasis, this woman has a history of hypertension and type 2 diabetes mellitus, both of which are cardiovascular risk factors. She has had bilateral knee replacements in the past. Okay, her meds include diclofenac, which is, as we know, non-steroidal. Aspirin, also a non-steroidal, but can be an antiplatelet drug as well, depending on the dose. Omeprazole is a proton pump inhibitor. Metformin, we know, is an oral drug in type 2 diabetes. Lisinopril is an ACE inhibitor. Amlodipine, a calcium channel blocker. And tramadol is a weak opioid. She's being treated with weekly oral methotrexate, which is the antifolate drug. It's one of the immunosuppressive drugs we have in our arsenal against connective tissue issues, principally rheumatoid arthritis and psoriasis. So she's on methotrexate for her psoriasis, and she has been treated with miocrystin and etanercept, both of which are biologicals, unsuccessfully for her psoriatic arthritis in the past. All right, so that's your basically her background and her presentation on history. And this is what the rash looks like. So it looks really like palpable purpura, right? This is a classic rash, especially of the distribution of the buttocks and the thigh that they give you in OSCE exams. Okay, so we're asking the question now, what is the differential diagnosis for this purple colored skin lesion? Well, purpura is one and vasculitis is the other. And purpura, as we know, does not blanch on pressure and it can be traumatic in origin, can be related to thrombocytopenia and abnormal clotting, or secondary to gram-negative septicemia. Then we've got vasculitis, in which we have the classic words. Whenever you see the words palpable purpura, you got to be thinking about vasculitis, guys. And that can be due to a wide variety of causes, from drug eruptions, infections, connective tissue issues, underlying malignancy. That's what we're saying in the box. Drugs, infections, connective tissue issues, malignancy. And if it's idiopathic, you're thinking Henoch-Schönlein purpura. All right. Okay. On examination now, this woman is pale. She's apyrexial, but she does seem to be in some pain from this rash. She has significant signs of chronic arthritis with ulnar deviation of the fingers. What else? So we know that psoriatic arthritis is a great mimicker when it comes to rheumatology. It can give you DIP predominant disease. It can look like rheumatoid arthritis with ulnar deviation, volar subluxation. It can look like uh, well, ankylosing spondylitis with the involvement of the axial skeleton. It can even look like we have telescoping of the digits. All right, so it's a great mimicker. All right, but this lady has signs of chronic arthritis with ulnar deviation of the fingers and reduction in grip strength. Now, she has also severely reduced range of motion of several large joints, but no evidence of active synovitis. That is something we always look for clinically in any arthritis patient or any patient for that matter. General exam, there's no features to cause concern. In particular, there's no breast lumps and no lymph nodes. Why are we talking about those two? Because those two could indicate an underlying malignancy. Just evidence of ongoing chronic plaque psoriasis on her back and the extensor extensor surfaces in the scalp, which is where psoriasis normally causes affectation, right? She has nail changes of pitting and onycholysis, consistent with her condition. What are the nail changes? What are the nail changes of psoriasis, guys? Pitting, hyperkeratosis, onycholysis, ridging, and discoloration. On her legs, she has this eruption which consists of individual scattered lesions which are both palpable and purpuric, ranging from a couple of millimeters to 5 centimeters in size. Some of these have vesicles within them, and the larger areas are beginning to show areas of necrosis and breakdown superficially. So we can say there's involvement of the epidermis. So has this really narrowed down the differential guide? This woman has florid vasculitis evident on the skin of her legs. Her meds really have not changed recently, so we can't implicate the meds in here. So it's unlikely that's playing a etiological role. Further investigations definitely needed to ascertain the causes of her vasculitis. So, in further investigations, guys, your analysis is performed to check for hematuria because we're looking for a prospective glomerulonephritis. We're checking for infection, which we're looking for renal involvement. So, then, we fondly do this in our patients in whom we suspect vasculitis. We do a vasculitis screen, full blood count, inflammatory markers, which is your erythrocyte sedimentation rate, your ESR, and your C-reactive protein, CRP. We do a renal function, so urea and electrolytes, liver function test. Then we do serum immunoglobulins. We do your anti-nuclear factor, anti-double-stranded DNA antibody. Some people do anti-Smith antibody, all right. And that's looking for lupus and rheumatoid factor, anti-CCP, which is anti-cyclostolated peptide. For rheumatoid arthritis, ANCA looking for vasculitis. So yeah, remember is ANCA positive and ANCA negative. Remember, when you talk about vasculitis, there's large, medium, small, and small is ANCA positive, ANCA negative. All right, viral and hepatitis serology, because those can also throw off vasculitis. Cryoglobulins, throat swab, and chest x-ray. The results of the investigations are shown on the next slide. And skin biopsy was done, which does indeed confirm, clinches the diagnosis of a small vessel vasculitis with leukocytoclasis. And a section of the biopsy is sent for immunofluorescence examination and shows deposition of IgA, IgM, and C3 within the small vessels. These are the investigations, guys. So our urinalysis was actually negative for blood and protein. Hemoglobin of 10.2. We don't have an MCV, but we can assume this is chronic disease, right? ESR 99, so that's high. CRP very high, 154. ANF is positive at 1 is to 40. Now remember, guys, the ACR EULAR criteria for lupus means you need to have a titer of at least 1 is to 80 or higher. So even though this ANF is positive, it doesn't meet the criteria to make us think about a diagnosis of lupus yet. Anti-double stranded DNA is negative, and this is very specific for lupus. So if that's negative, that effectively rules it out. ANCA is negative, so there's not a small vessel ANCA positive vasculitic syndrome. And you think about things like Wegener's, which is GPA, and then previously Church-Strauss eosinophilic GPA, and MPA microscopic polyangiitis. All of those are negative here. Rheumatoid factor negative. Cryo is negative. Serum immunoglobulin G is normal IgM, normal IgA elevated. Aha. So remember that Henoch-Schönlein purpura looks like IgA nephropathy on renal histology. Hepatitis is negative, viral serology is negative, chest X-ray shows just mild cardiomegaly. That's probably on account of long-standing hypertension that she has. So the histology confirms the diagnosis of vasculitis, so we happy about that. But this is not just any vasculitis, this is leukocytic vasculitis with the presence of a large number of neutrophils. Now, this in context with the direct IFA result and elevated serum IgA means that we're probably dealing with the idiopathic form of vasculitis, Henoch-Schönlein purpura. This condition can be seen at all ages and has no real precipitating cause of load. Um, yeah. How will you treat her? Well, I included the treatment names in yellow, guys. So, in view of the severity of this rash and the local areas of ulceration, or oral prednisolone, so a systemic steroid, is started at a dose of 40 milligram daily, which is about 0.5 milligram per kg daily. And the effects of prednisone on her diabetes is likely that she will need insulin temporarily because it's going to bump up your glycemic control. Topically, a very potent topical corticosteroid. In this case, we use clobetasol propionate 0.05%, applied 12 hourly to the lesions on her legs, and a topical antibacterial cream, while silver sulfadiazine cream does a great job. Under a gelineate dressing are applied to any ulcerated areas. For psoriasis, simple topical emollients are used. As the rash improves, then you can gradually taper her oral steroids. In the case of severe recurrent attacks, you want to consider an alternative form of immunosuppressant, such as azathioprine, not just for disease control, but also for steroid-sparing effect later on. The systemic steroids are phased out over several months to avoid a significant flare-up of psoriasis, guys. So this is the key points for palpable purpura, guys. About half of all cases of leukocyte classic vasculitis are idiopathic, important. The most common cause of vasculitis globally is likely to be post-infectious. Appropriate screening investigations are required for local concerns and risks. Around 1% of cases are due to underlying malignancy, which, if suspected, should be investigated by appropriate directed tests. And besides the skin, the most commonly affected organs are number one, the joints, two, GI tract, three, the kidneys. So screen for disease in those systems. Renal involvement is the most serious complication of vasculitis. Involvement of the kidneys should be carefully monitored and investigated early if suspected. Although leukocytoclastic vasculitis is more common amongst the younger folks, there is a significant incidence amongst older people. In the elderly, there is significant risk of GI involvement when it comes to HSP, Henneck-Schönlein purpura. Okay, my friends, let's look at, we're looking at the humility of Jesus. Humility in him coming down to earth, humility in his earthly life, right? In Jesus was life, and that life was the light of men. And so we look at the life of Jesus to give us revelation on God's purpose for mankind. And in this context, I remember when Jesus washed the disciples' feet when they celebrated the Passover just before the crucifixion, and they went to the upper room. Now, in the upper room, table was laid. There was no slave. Right now, as a commonplace in those days, if you enter a wealthy home, washing of the feet was normally done by the slave. Now, note that a slave is bought and doesn't receive wages. Paul says we are bond slaves of Jesus, of Christ. We want to serve God and serve others. Now, anyway, the job of the slave was to get a basin of water, remove the sandals of the guests, and wash the dust from their feet. Because in those days, the way people commuted was walking, right? And they wore sandals, and so their feet would be dusty. And so it was the job of the servant to get the basin of water and to wash the feet of the guests before they recline at the table to eat. Now, whenever there was dinner, there was a basin of water at the door. So this is just to give you some context, guys. So they probably thought, who is going to wash our feet? Now, all the disciples must have thought, okay, fine, there's a basin of water, we're ready to eat, but who's going to wash our feet? And they must have all had some kind of thoughts of superiority about themselves. Peter probably thought, listen, I'm going to be the next leader, so I'm not going to wash people's feet. Matthew probably said, hey, I'm an accountant, I'm an accountant, and I certainly can't get down and wash people's feet. They must have all thought themselves superior in some respect. But then Jesus, with a servant-like attitude, he takes the basin and he washes their feet. Now, is it because Jesus thought that he was better than them? Certainly not. Jesus was the holiest, most humble man. The thing was that he valued his disciples more than himself. He values others as more significant. He sees something of the nature of God in everybody. And likewise, when we see the nature of God in everybody, we will not have a problem serving them. One of the Beatitudes is, blessed are the pure in heart, for they will see God. If your heart is pure, you see God in everyone and in every situation, right? Because you know that these people are made in the image of God. Amen. Here are my references, everybody. God bless you. I'll catch you on the next video. Much love.